Okay, as you guys might have seen on some of the trucks, we've got some new medications that have come out. I know they're on Medic 5 and they'll slowly be making their way to the rest of the trucks. So I thought we'd have a little medication guideline update so you can see what's going to be on these medic units and become familiar with them. Here's a list of them. Some of them are new. If you were with West I-10, you've seen Toradol before with us, and you've seen the DUODOTE injector, auto injectors. So a couple of these are going to be back on the vehicle, but as far as some of the other stuff, it's new for our department. So we're going to go through them. The first one will be DROPERIDOL. Second one will be KETOROLAC or Toradol. Third, NICARDIPINE or Cardine. Fourth, TRANEXAMIC acid, which is TXA. The next one, ESMOLOL, and then finally the DUODOTE auto injector. So let's get started so you guys can figure out what these are. First one we're going to talk about is DROPERIDOL. This is a paramedic supervisor or advanced level skill. Unfortunately, the AEMTs won't be able to do this. And we're going to use this primarily for sedation for anxious or agitated patients who's disruptive, but not necessarily a danger to themselves or others. That doesn't mean that they're going to be cooperative. It just means that they're not to that excited delirium stage where ketamine is definitely going to be our primary drug of choice. It can also be used for intractable vomiting that's not controlled by either Zofran or promethazine that we carry. Intractable vomiting, it's basically vomiting that's difficult to control. It doesn't lessen with time or traditional treatments, and it's usually accompanied by nausea when you constantly feel as if you're about to vomit. So just keep that in mind. Contraindications of this drug, obviously, as with any drug, any known drug allergy, any known long QT syndrome, and any QT prolongation on an EKG. Obviously, our cardiac patients may know they have these issues, but most of the time, in my experience, people don't know. If you're not familiar with a long QT syndrome, it's a condition in which repolarization of the heart after a heartbeat is affected. It results in an increased risk of an irregular heartbeat, which can obviously result in fainting, drowning, seizures, or sudden death. So we definitely want to make sure we are doing a full assessment and getting a full history on our patients. All right, so how are you going to use it? Well, we're going to use it for sedation. The first part of this, we're going to draw up 5 milligrams of the DROPERIDOL with 2.5 milligrams of Versed. It's going to go in the same syringe, and then you're going to administer it in the IM lateral thigh, just like we would if we were using an EpiPen. Again, just keep in mind that your patient is probably not going to be very cooperative, so proceed with extreme caution. Make sure that you are looking out for your partner, and your partner is looking out for you if this is going to happen. The syringe that we want to use is that retractable syringe. Again, for safety reasons, we don't want any accidental needle sticks. When you administer it, your patient's probably going to get extremely drowsy. They may not, but at least expect that. Once you've given it, try to get a 12 lead. Try to get it beforehand, but again, if your patient's not cooperative, let's get them slowed down and sedated before you attempt a 12 lead. Afterwards, if you can't get one before, make sure you get one afterwards. Monitor the EKG. Keep them on the monitor for the duration of your transport. And these obviously are a mandatory transport to the ER post-administration. We are not administering medications and putting them in the back of police cars or leaving them at home. And of course, if you need to continue to sedation, you decide to go downtown or something where you've got to give another round of sedation, give Dr. Gill a phone call so that he can advise you as to what to do. If you've got that patient that is going to have that intractable vomiting, you can use it with Zofran, but we're requesting that you're going to call the EMS physician for the use of this. if somebody is vomiting and nothing else is working, there's a good chance they're dehydrated, their electrolytes could be off. There could be other issues going on that we're not fully aware of. So we want to make sure we talk to the doc. Again, get a full history, get a full assessment done. Don't just go by what you see. Our dose here is going to be 1.25 milligrams IV push. All right. The IV dose is only for the intractable vomiting. That is it. We're not giving an IV dose for sedation. The sedation dose will only be IM. The vomiting dose is IV, and that is it. And if you need that little hint, intractable vomiting, IV. So there you go. Came up with that on the fly. All right, side effects. We've talked a little bit about the EKG changes, prolonged QT syndrome, tachycardia, hypotension, neuroleptic malignant syndrome, dizziness, and dystonia. I will try to put in the notes here the link to this article. It was pretty good. It discusses a little bit about what neuroleptic malignant syndrome is, and that it can be, I don't want to say easy to miss, but we get caught up in other things and we do miss it. Tabor's Medical Dictionary defines it as a potentially fatal syndrome marked by hyperthermia, catatonic rigidity, altered mental status, profuse sweating, and occasionally rhabdomyolysis, renal failure, seizures, and death. It typically occurs after exposure to drugs that alter levels of dopamine in the brain, such as antipsychotic agents, or after the withdrawal of agents that increase CNS dopamine levels, such as levodopa and carbidopa. The death rate can be as high as 30%, so we definitely want to make sure we're watching this. Antipyretics, curare-based paralytic drugs, which rocuronium is one of. Bromocriptine and dantrolene are used to treat this syndrome. So if this has to be given and you start to see these effects, get to your nearest emergency room as soon as possible. All right, so let's move on to the next drug, KETOROLAC or DROPERIDOL. Again, paramedics can give this, supervisor, or the AP paramedic. So how is it supplied? Well, there's 3 ways it can be on our truck, and you guys know, just like I do, that it is all dependent on what is available when we are purchasing. So always make sure you're looking at those labels. Make sure you know the dose you're drawing up, and so forth. Obviously, the first one, it's 15 milligrams per milliliter. Second one, 30 milligrams per milliliter. And then the last one, the pre-filled syringe there, again, 15 milligrams per milliliter. You do want to make sure you know what you're drawing up. And these are just the colors that are out there now. You know as well as I do, these colors could change. The packaging can change. We are at the mercy of the distributors when they come out with these. So always, always, always read your labels. These particular images are taken off the internet. So it's not necessarily one of these we're going to carry, but as you start checking off your trucks in the morning, become familiar with the drug and which dose we've got on the truck, okay? Indications for this, mild to moderate pain control, suspected kidney stones. This is the big one we typically give it to, people with kidney stones. And then secondary fever control. It is an NSAID, so keep that in mind when you're giving it. Our contraindications, obviously, again, known allergy. Any active bleeding or known recent bleeding that's going on, current use of NSAIDs, and anybody that has a risk for bleeding or if they are on blood thinners. Again, Toradol is an NSAID, and based on the medication guide that comes with this medication, it can increase the risk of heart attack or stroke. If you have a patient that you expect an MIN and you suspect that they may have to go under surgery for CABG, don't administer this. And really and truly, just if you have that cardiac patient, maybe look at some other things, but definitely use extreme caution in any cardiac patient with this. So how do we use it? 15 milligrams IV or 30 milligrams IM for mild to moderate pain control, depending on if you have access. If you're doing it with a fever, 15 milligrams IV or 30 milligrams IM for a fever greater than 102, secondary to acetaminophen. So if they've taken acetaminophen or Tylenol before you got there. It can be your next drug. If it's for if you're giving the Ofirmev, you can use it secondary to Ofirmev, but you want to give it really more for pain there in that event. There are no pediatric indicators for this medication, so we are not giving this to peds. Again, it can be given for fever if acetaminophen was already taken. It is not primary for the potential surgical patient. Again, there's a bleeding risk there. If you've used it and you still need additional pain control, go fentanyl or ketamine, not both, one or the other. And that can be your secondary pain dose that you can use. And again, I think I misspoke before, just to be clear, you can use this in conjunction with Ofirmev, but for pain only, not for fever. If you're going to give it to them for a fever, they would have had to take acetaminophen already. Okay, does that make sense? Because obviously if we give the Tylenol, we want to give the Tylenol time to work. So I hope I didn't confuse anybody there. Side effects: GI bleeding. Again, that bleeding. Headache, nausea, abdominal pain, dizziness. A lot of the things that a lot of different drugs can cause. So keep that in mind. If they've got a history of GI bleeding, don't go with this. We can look at other options. So that's it for Toradol. Let's move on to Nicardipine. All right. So this is a calcium channel blocker indicated for the short-term treatment of hypertension. The supervisor or advanced paramedic is going to be your primary people that can administer this. If you've really got that stroke patient and the supervisor's on the other side of town, make sure you are calling them, consulting with them, or worst case scenario, calling Dr. Gill. You can't get a hold of supervisor, or the supervisor's too far away, call Dr. Gill, get that medical control from him and get it started. But don't necessarily wait for a supervisor to get on scene if your patient needs this medication. Indications: symptomatic hypertensive crisis. You've got that patient that's blood pressure's through the roof, they've got headache, and maybe they're even developing stroke-like symptoms. Maybe a stroke, it may just be severe hypertensive crisis. So that's what it's going to be there for. Or you do suspect a stroke and they've got a systolic pressure of greater than 200 and or diastolic pressure greater than 110. This is when we're going to use this drug. Again, our contraindications: known allergy, asymptomatic hypertension, and advanced aortic stenosis. You don't want to use the nicardipine in patients with advanced aortic stenosis because of the afterload reduction effect of nicardipine. Reduction of diastolic pressure in these patients may worsen rather than improve myocardial oxygen demand, and that comes right from their prescribing information sheet. So keep that in mind. If they have a history of that, you probably want to steer clear of this. Or at least, give the doc a call and let the doc know what's going on. So how do we use it? Well, this is going to be one we're going to mix and put into the IV pump. You're going to place 25 milligrams in 250 milliliters of D5W, and that'll give you 0.1 milligrams per milliliter. Our typical dose for this patient is going to be 50 milliliters per hour or 5 milligrams an hour through the pump. If you have symptomatic hypertensive crisis or stroke, that's going to be your dose, 5 milligrams per hour. Again, we talked about what your systolic and diastolic should be, greater than 200 and or 110. But if you are starting to administer this and you notice it's either not working or it's just not coming down like you need it to, then you're going to increase by 2.5 milligrams per hour every 10 minutes as needed to a max dose of 15 milligrams per hour. We're looking for a 10 to 15% reduction in that systolic pressure. We're not trying to get them down back to, quote, normal levels. We want a 10 to 15% reduction in that systolic pressure. So that would be 20 points. So maybe from 200 to 180 to make it for simple math. So keep that in mind. Drug incompatibility in this. It won't work if Toradol is being used. Believe it or not, we just talked about that, and of course, we don't want to use it with sodium bicarbonate. Again, this is a medication that is going on our pump, so please make sure you are familiar with the pump and how to program it. And again, you want to monitor for that target reduction, and then once you hit that point, you want to titrate down to just maintain that. We don't want to dump their pressure so much. So target that reduction and then begin to titrate it to effect, okay? So side effects on this, we're looking at some angina exacerbation, AV block, headache, peripheral edema, hypotension, palpitations, nausea, vomiting. Some of the most common adverse reactions to this are headache, hypotension, tachycardia, and of course nausea and vomiting. So definitely make sure you manage that airway as well if you have that nausea, vomiting. We want to make sure that we don't have aspiration. So if you need to intubate, definitely intubate. All right, moving on to tranexamic or examic acid, or TXA. Again, supervisor or advanced paramedic level skill. But this is going to be our drug for trauma or bleeding, okay? Indications: blood transfusion, hemorrhagic shock, trauma or OB, and or traumatic brain injury. Now, we're going to talk a little bit more about that traumatic brain injury when we get into the, when we give it and whatnot. So just keep in mind, mainly this is going to be a lot of bleeding. Bleeding is involved with TXA. Let's keep it that way. Contraindications. Obviously, again, a known drug allergy. We will not give it to GI bleeds. The injury is no greater than 3 hours. OB bleeding, greater than 3 hours. Hemorrhagic stroke. Non-traumatic head bleed. Now you might be thinking, why 3 hours? Well, 3 hours is our window. All the studies that have been done, 3 hours is your window for this drug to be effective. The problem that we have with GI bleeds and hemorrhagic strokes is we don't know when the bleeding started specifically. Same thing with a non-traumatic head bleed, which really is more or less a hemorrhagic stroke, or maybe we're talking about an aneurysm. But if we don't know when that bleeding started, we cannot give this medication. And 3 hours is your window. Don't get to that 3 hour mark and just be like, oh, let's push it over the edge. 3 hours. We're going to hold fast and true to that number. So 3 hours at this point. Unless you hear something different from Dr. Gill, Dr. Reiniger, or Eric, 3 hours is your window, and that is it. Okay? So, how do we use it? Well, there's two ways we can give this drug. All right? And again, the circumstances of your call will dictate that. But first way, we're going to take 2 grams. We're going to mix it in a 50 milliliter bag of normal saline, and we are going to run it wide open. This is usually going to be like over 10 minutes, but it's just going to be wide open. It's going to get in pretty quickly. Again, we're probably using a large bore IV for this, so it's going to go in quickly. All right. Always infuse this on its own IV line. Okay. Especially don't give it if you're giving blood. If you're giving blood, or you're going to be giving blood through that same line, make sure you have your own separate IV line for this, okay? And again, I'm going to reiterate this. Don't give this if you don't know when this bleeding started, okay? Because it's not going to be good for the patient. All right, our second way to mix this is now we're going to take 2 grams, draw it up in a 20 milliliter syringe, and give it slow IV push. Okay? Typical dose of this is 2 grams IV infused on a secondary set, or 2 grams in a 20 milliliter syringe, slow IV push. All right? So give it slow. Give it over a minute or two. Longer if you need to, but we do not want to slam this medication. Okay? And then just make sure you flush it slow as well. I know sometimes people are like, oh, I've got to give this slow. They get it in. They're giving it maybe through a lock. And then the next thing you know, they grab their flush and they slam what's left. We don't want to do that. Let's give it slow. Let's do it right. Let's give the patient the best opportunity for survival that we can. Some of the side effects you'll see with TXA: thromboembolism, seizures, again, the nausea and vomiting, and hypotension. And if you think about these, we've got an open wound of some sort if bleeding is coming out. So the opportunity for a thromboembolism is high just on its own. Seizures can occur due to the fact that the patient is losing blood and oxygenated blood is not getting to the brain. Again, nausea, vomiting because of a head or neurological issue based on the lack of blood getting to that brain can happen. And again, we're losing blood, so hypotension's a very, very strong side effect. So that's why we want to make sure we get it in there. Treat your triad. Make sure you're giving your patient the best opportunity for survival. So let's move on. Now, ESMOLOL's been on the truck for a little bit now. We've used it a total of 6 times at this department that I've seen. It may be up to 8 now, but it is a beta blocker. It is given by the supervisor or the advanced level paramedic. And our typical indications for this are going to be refractory VFib or pulseless VTAC. The second thing is post-cardiac arrest. Okay, so cardiac arrest, and as we get into the other slides, you'll see exactly when to give it. But that's pretty much all we're looking at. You've got somebody who has been in VFib or pulseless VTAC for quite a while. Obviously, that is a cardiac arrest. And we're going to attempt to give this. At this point, in the emergency setting, which cardiac arrest will be, there's no contraindications. If we need to try to use it, then we need to try to use it. But how do we use it? Well, the first thing we're going to do is we're going to draw up 40 milligrams, give it IV over 1 minute if we've got refractory VFib or VTAC. And then we're going to take the rest of it, because it's going to come in a 100 milligram vial. We're going to take the rest of that 60 milligrams, we're going to mix it in 50 milliliters of normal saline, and we're going to administer it over 10 minutes. Now, if our patient changes that rhythm and they go into asystole, or we get ROSC with hypotension or bradycardia, we are going to discontinue it right then and there. So make sure you're watching that monitor, you're watching your patient, because if they go into asystole or they go in, or we get ROSC but they're super hypotensive or bradycardic, stop it. We are not giving this medication to pediatrics, so keep that in mind. Now, everybody has heard the term refractory VFib, VTAC. We all know that it's definitely a shockable rhythm. Typically, you're going to have that end tidal of greater than 20 that hasn't converted. So they're just in that VFib, VTAC, and it's just not changing. When we use this, we want to make sure that we have administered 3 shocks. We have given 2 milligrams of 1 to 10 epinephrine, and we've given 300 milligrams of amiodarone, or if we're using lidocaine, 1.5 mg per kg on that. Keep in mind, you do not want extravasation to occur because it can cause tissue damage or necrosis. So make sure that line you're putting it in, if it's an IO, or if it's an IV, make sure it is good, okay? And then, again, we don't want to give sodium bicarbonate through the same line. So make sure you have a second line if that's something you're considering on your patient. Some of the side effects we can expect to see. Congestive heart failure, well, that makes sense in a cardiac arrest patient. Severe bradycardia, well, we are dealing with a beta blocker, so there you go. Heart block, tagging along with that bradycardia, we're probably going to see some hypertension, and then maybe a bronchospasm. So again, hopefully we've secured their airway and we can give them what we need. All right, the last medication I want to talk about with you today is that DUODOTE auto injector. It is a mix of atropine and, I'm going to butcher this, but pralidoxamine, I think. This is in the jump bag. An EMT, an advanced EMT, a paramedic, a supervisor, or an advanced paramedic can give this, because we are giving this to ourselves, okay? We are giving, so we have had an exposure. Imminent distress from organophosphate exposure, whether chemical or organic, is when we are using this. And again, we're using this for us. This is not one that we're giving out to other patients unless there's some way to confirm that we have not been exposed. The only contraindication is any pediatric patient that is less than 40 kilograms. So about 80 pounds, a little bit more. All right, so how do we use it? Well, it's an auto-injector. We're going to use it the same way that we use an EpiPen. All right, so if you have, and this picture, I put both of these on here because it's going to come in this little packaging, but when we open it up, it's the auto-injector pen. So when you're going through, so just so you recognize, oh, it's in that little film-colored looking packaging, for those of you that know what old film looks like. If you're exposed to a mild, I guess, exposure, you're going to give or administer 1 duodote IM left lateral thigh. And then you'll repeat it as needed every 15 minutes, up to 2 times, if you're not improving or you have worsening signs or symptoms. Okay? If you've been severely exposed, we're getting 3 of these babies in the leg. Okay? We might have to get more, but you'll be getting 3 duodote auto-injectors in your left lateral thigh. It's going to work just like an EpiPen. Just make sure that the tip of it is going to be green. That is where the needle comes out. Do not put your finger down there. If this is being administered to you, these are the side effects: blurred vision, dry eyes, confusion, headache, dizziness, arrhythmias, hallucinations, hyperthermia. Now, you can have some of these as well with just being exposed. So just know that these are the things that could happen. A couple things to note well on this one. You've got to be decontaminated prior to transport. We don't want whatever is on you getting into the back of that truck. Also, it's going to have less efficacy on the 4th generation nerve agents. So in that event, just keep in mind. And do the best you can with this. Hopefully, we've never had to use it. Hopefully, we never do. So keep that in mind as you go. As I finish this up, if you've got any questions at all, feel free to reach out to me. If I don't know the answer, I will find out the answer. You are always welcome to reach out to Dr. Gill. You're always welcome to reach out to Chief Bank or your supervisors as well. So hopefully as you move forward, this gives you a little bit of an introduction into those medications. And if we get questions on those, then I will try to dig deep and find some more answers out for you guys. Here's the references of what we used for this presentation if you guys are into that. I've got 3 pages of them here. You can always reach out to me as well if you wanted to look at these things or if you're interested in an article or 2. Okay? Thanks for taking the time to do this, and we will have more training coming out soon. Okay? Thanks a lot. Y'all have a great day. Bye.